forward, we have a very pertinent topic, interprofessional health education. This topic has caught the attention of everyone as it offers many advantages and benefits to the healthcare vertical of human society.
The Lancet Commission report on transforming education to strengthen health systems in an interdependent world states that the multidisciplinary and systemic approach for health professional education is the need of the day. Transformative learning, with its focus on the development of leadership skills and interdependence in health education, engages the needs and demands of the 21st century health professional education. Conventionally, health insurance, pharmaceutical, information technology, entrepreneurship, and healthcare administration have been key verticals in healthcare management. Traditionally, nursing, physiotherapy, nutrition and dietetics, and medical technology fall under the allied health sciences domain. The key verticals of healthcare and allied health sciences face multiple challenges. It is a well-accepted fact that diverse forms of disciplinary and experimental knowledge are required to understand these challenges and develop workable solutions. We have all cadres of health professionals in the audience. Hence, it is relevant to have this talk today.
To elaborate more on the topic, we have Dr. Sanjay Oak with us today. Dr. Sanjay Oak, Chief of COVID-19 Task Force, Maharashtra. He is a renowned pediatric surgeon with more than 37 years of clinical experience. He has established a liver transplant unit in KEM Hospital and has established a medical simulation lab in DYPU, University, Mumbai. He is a member of the National Protocol Design Team and has published more than 250 scientific papers. We request Dr. Sanjay sir to come and address the audience.
Strange to have an administrator soft-spoken, but that's what it is. So Muzumdar sir, regards to you. Very happy to see my friend Jamkar sir with me. Has always been a pleasure to come back to Pune, city that made me, and visit Symbiosis. When I was in my shorts peddling Ganesh Khend Road, Symbiosis' first building was coming up. So I have very fond memories with this organization, sir. The topic that has been given today by Rajiv to me is interprofessional health education. What are the missing links? Having spent precisely 40 years in surgery, last 17 years at the helm of affairs in the state, in medical education and in health sector dispensing, I would very, very strongly say that the last 2 years changed me maximally as the chief of state's COVID task force. Rolling all the protocols, the best lesson that I learned was coming together. If you forget the whole presentation, just remember one slide of hugging 3 different professionals who matter the most in the management of patient care. This is what was missing. Dilip Kumar ji very rightly said, "Tankwa de do unhe." I've been harping on for these 3 deficiencies in the Indian nursing skills: salary and social status. These are 3 S. If we improve upon, our nurses are second to none in the entire world. And COVID proved that we were better in most of the Western world as far as at last the state was concerned. We could have done better. We could have done better. And I almost talk every day night with the Honorable CM, harping this note very clearly that, sir, we could have done better. But nonetheless, whatever we have saved proved that West, W-E-S-T, at times was West, W-A-S-T-E. And the solution lied in emerging solutions that matter most to us. You know, dear friends, this is a silo. सायलो म्हणजे ज्याला मराठीत आमच्या सांगलीच्या बाजूला हळदीचं पेव असं म्हणतात. It's a huge tower erected where you store grains. धनधान्य साठवण्याचं गोदाम म्हणजे सायलो. याला दुसरा परिकथेतला शब्द म्हणजे आयव्हरी टॉवर. In health sector, we build silos and ivory towers, but don't talk to each other. There's no question of any interprofessional problem. Rajiv, this is the first missing link in the health sector management of India. So these are the occasions when students from 2 or more professions in health learn together and they cultivate collaborative practices. This is interprofessional education. So dear friends, let's make an effort in the next half an hour of looking out what are the barriers, what are the obstacles, and are there any solutions. Being a very practical surgeon who operates every day morning, I believe at times more in knife rather than dialogues. Some of you might be born after Lavaris, but I'm sure you all know this song, मेरे अंगने में तुम्हारा क्या काम है. This is the problem with the health sector in India. A doctor asking a nurse, a doctor asking a physiotherapist not talking to an occupational therapist, and all of them not talking to the healthcare policymakers. And the healthcare policymakers not talking to anyone. Why? मेरे अंगने में तुम्हारा क्या काम है. But dear friends, this comes from probably Muzumdar sir's youth. And this is thespian Dilip Kumarji. And the song went as Sathi Haath Badana, Ek Akela Thak Jayega, Milkar Boj Uthana. That is what is required for the healthcare sector today. What did we do? What did we do differently in the last 2 years since 11th of April 2020 at 11 p.m. when the task force was constituted? We broke down the barriers. We broke down the barriers. I'm a super specialist surgeon dealing with 1-day-old babies. Forget it. That's not required. What is required today is to sustain a life, to salvage somebody. I'm an orthopedic surgeon doing spine. Forget it. Come together to turn a patient prone, supine in ICU. I'm a physiotherapist. Come and help me for my chest management. I'm a policy maker. Allocate right kind of funds for the right purpose. So dear friends, we understood each other better, and most important thing, we understood the patient better. It has been 75th year since freedom. One of the glorious mistakes that India has done, irrespective of party politics, is a divide between public health sector and private health sector. I worked at the topmost positions in both, and I can tell you with conviction that there are good people, excellent people in public health sector, and there are excellent people in private health sector. The problem is they don't talk to each other. And that is where we need to come together. So interprofessional education is learning. Learning with each other, learning from each other, and learning about each other. Remember this slide. This is what IPE means. If you forget my today's talk of 40 minutes, doesn't matter. Remember only one slide to become successful in your career. Talk less, listen more. We do just the reverse. And that's the problem that gets us to the current situation. Why do we need IP? Finally, we need IP for all the good health indices and parameters. So we need 7 C's. Having been a management, initially a student, and I'm always a student of management, and now a faculty on almost all the management colleges, I have been a habit of 7 C's of this, 7 A's of this, 7 A's of this. Saatach ka? I don't know. Perhaps it's the influence of Pune, Sachat Gharat. But then these are the 7 C's of care. It has to be collaborative, work together. It has to be comprehensive. Finally, when you are bringing the bubble together, everything is included in that particular hemisphere. It has to be contemporary. You can't give care of 1947. I passed my pediatric surgery masters in MCH somewhere in 1988. Today, what I do is nothing of that, but it is contemporary. What was talked about in 2010-11, those are the surgeries that are being done. It has to be cohesive. What is cohesiveness? If you have a toddler in your home, give him a jigsaw puzzle, and I challenge you that he will mark and get those pieces quickly together, completing the puzzle faster than what an adult can do. That is cohesiveness. That is how we should gel with each other. Competence comes with work. Compassionate. This is something we tend to forget. More the technology gets added, more mechanized you become. I'm just finishing my 53rd book in Marathi, and I've written a chapter on Sahavedana and Samvedana. Sahavedana is becoming compassionate, empathy. So the group, when it comes together, it should become more compassionate towards the patient care. And yes, it's not that I'm excellent today. Today is NAC inspection. My college is going to be accredited. Everything will be chakachak. Tomorrow, gaye NAC. It cannot be that. It has to be continuous. It has to be every day for every patient. One size does not fit all. Please remember that. You have to tailor-make. It cannot be a Park Avenue suit bought from Raymond's. Apart from being a surgeon and an administrator, I'm a fairly decent cook, and I like to cook my food. If you give me raw chicken, these are all the various preparations that I can make. At least make up to that level that at least I can eat. I don't know about you. So the point is, it is the same education. It is the same principles of patient care. It all depends on how you design it. So the healthcare dispensing and education is how you design it with the help of your colleagues. For that, you need to network. You need to network amongst yourself, amongst the institutes of your umbrella, and even the neighboring ones. So which are the healthcare disciplines, dear friends, that we are looking at? We are looking at doctors. And when I say doctors, I include allopathy as well as Ayush. COVID 2 years have proved that point, that Ayush practitioners have done as good as the allopathic practitioners. And there is no point any organization of just the MBBS people thumping their chest that we are the best. No, everyone was there together. Then there is nursing. Then there are physiotherapists and occupational therapists. Don't forget the pharmacy. I work on pharmacy council and give them lectures, and I call them as health sector ambassadors. They are the last point of contact with the patients when the drug strips are being handed over to the patient. Patient has myriad of questions in his mind which he is afraid to ask to his doctor. साहब, ये गुली पानी के साथ लेने का कि दूध के साथ लेने का? नहीं, साहब पानी के साथ लेने. साहब पानी उबाल के लेने का कि ठंडा लेने का? नहीं, भैया पानी ठंडा लिया तो भी चलेगा. साहब खाना खाने के पहले लेने का कि बादन लेने का? नहीं, भैया खाना खाने के बादन लेने का. अच्छा, साहब हम लेने का या हमारे भाई जी को देने का? So pharmacists, don't forget them. A cadre which unfortunately has not yet been developed properly in India. And I entirely agree with Dharmendra ji, Dilip Kumar ji. It is not the education or the university. It is the lack of jobs on behalf of the government that's a key root of all these problems. Private sector will follow when the public sector makes it. Private sector will always try to undercut the money. There's no doubt about that because they have their own issues of sustainability. But we should have jobs created for all these cadres at the level of central and state government. But the problem is when you talk to center, they say, अरे भाई ये तो state का subject है. And when you talk to state, state says, सब पैसा नहीं आता ना, इतना GST भी बचा हुआ है, salary देंगे कहाँ से? The outcome of all these badminton game is what we are today. So you need paramedics. You need medical social workers. You cannot forget their role in the counseling. You also need prosthetic makers and biomedical people in that. And the last but not the least, you need administrators like me. So what does IP involves? IP involves educators and learners from two or more health professions. What are the professions? We will discuss ahead. What do they foster? They foster a collaborative learning environment. Sahano bhunaktu, sahaviryam karvavahi. That saha is important. So it fosters that relationship. It integrates the whole concept and it modifies behaviors and brings out the best of competence. What is not IP? Now this is important. Students from different health professions sitting in a classroom, there are some common topics and there are less teachers. There may be less classrooms also. So what do? Hey, nursing 3 to 5 idhar aao, medical college first MBBS 3 to 5 idhar aao. They're all put into one classroom and one teacher teaches. This is not interprofessional education. So mere physical presence means nothing. Why? Because there is no reflective interaction. A faculty member from different profession. Okay, I go and give a lecture to nursing, which I've done quite often in my career. Is that IPE? No, I'm sorry. Even this is not IPE. Because no decision making or a responsibility of patient care is being shared. So please remember this, that this is not IPE. So what are the essential ingredients, if you want to classify something as an IPE? You must have a structured pre-brief discussion that this is what we need to have. The senior people must meet over a cup of tea and discuss that. You should develop robust scenarios. How? We will discuss in some examples. But you should have a roadmap planning. As from today to next 3 years, this is where we want to go. Incorporating the curriculum. This is the most difficult, the most challenging aspect. I've been a vice chancellor of a deemed university, and I'm happy to have led the deemed university because the type of freedom that the deemed university enjoys under the UGC provisions, a standard university at times finds it difficult to make changes. Both may be right. But if you are a part of deemed, I think it would be more expected of you to go ahead with new things, to go ahead with new curriculum. You again cannot copy-paste things from here and there, but you need to involve into a jigsaw puzzle. Kindly remember that. Then you must plan how to execute. Now here comes the role of simulation, which I will touch upon. And then most important, if you are getting simulation in your university, the success of simulation lies in structured debriefing. It is not doing, but it is letting them know that these things were wrong. And then a feedback that comes out of it. You need to monitor it. It can't be things like that Muzumdar sir told he's the person involved and let go. No, it cannot be like that. Because in today's world, evidence will be asked at every step. So whatever you follow, it has to be an evidence-based practice. Quality has to be the buzzword. And how our tomorrow will be better than yesterday or today, that is what matters. So you have all the data which is being gathered and which would be subjected to statistical analysis. Which competencies in my mind, as a vice chancellor, what I aimed at and what I did for 4 years, 5 years in DYPU, in my students. First is team building. See, unfortunately, everybody in health profession wants to become Sher Shivaji. Absolutely well taken. But Sher Shivaji also became Chhatrapati Shivaji Maharaj because they were Mavalas and he cared more for them rather than for anyone else. That was team building. So in medicine, nothing happens with me. If I'm doing a complex liver surgery on a given day, it is everyone, right from my scrub nurse, circulating nurse, my anesthetist, my ward boy, everybody matters. This is interprofessional execution for a common goal of saving a life. So team building. But leadership, I'm the captain of the ship. So anything going wrong, I won't blame others. I won't shout on them. You have to take the onus of responsibility. Communication, fostering respect. You don't acquire respect by being a director or VC or a director general or anything. In my life, no chair has ever stuck me to the posterior aspect. I have said it's not the chair, it's what I do after sitting in that chair that matters. And that is why I think I get the respect that all the institutes I have laid up till now. You have to have a mutual trust. I must believe my nurse. Every day in the morning when I see my favorite nurse, that favoritism, that respect comes because I know she has done whatever I need, she's already kept the things ready. That is mutual trust. Resolving conflicts. Wherever there are individual, there will be issues. घरात भांडणं होतात तर ऑफिसमध्ये होणारच. कॉर्पोरेशनमध्ये किंवा एखाद्या ठिकाणी काम करताना कारखान्यात हॉस्पिटलमध्ये भांडं लागणारच. You have to get to an art of resolving conflicts. Now, no medical college or management college teaches you these things. They only teach you how to resolve in a theoretical manner. How to actually resolve, you have to sit in that chair and then take the role. When I was leading KEM, I had 8 political unions, all having about 4,000 staff amongst them. But finally, you have to take the hospital ahead, the healthcare ahead. And that is possible if you learn the art of resolving conflicts, overcoming barriers. And what are the barriers? We'll come to that in a minute. Let's touch upon this important point since you are academicians. And if you want to go in for IPE, how to design a curriculum. That is the most important point. Are there any tips for that? Yes. First of all, performer needs assessment. Whatever this IPE I am going to do, is it required? Are there any takers in the society? If there are no takers, then probably my things are not going to work. As Dilip Kumarji very rightly said, 14 super specialty nursing courses. Why would they take? If you have not created a position, that means the need was not created. Something sometimes needs to be created. And that's the same sentiment that he echoed in his earlier presentation. The performer needs assessment as to what is the need of the hour. Gather the data. Where do we stand today? What are the numbers and what is the quality? Agree upon learning outcomes. We may be 3 or 4 persons sitting from different category. Each one of us will have to keep our cabin baggage behind. And we'll say, yes, finally, this is what we want to happen. The success depends if the outcome is planned before you commission a program. Please remember that. Objectives have to be smart, specific, measurable, accountable, replicable, and in a specified time frame. Teamwork is the watchword, and create scenarios to integrate. Again, custom make the programs. Once the curriculum is decided, come down to the level of the programs. From the programs, go into the level of the tasks. That is the way to execute a thing. Make reverse engineering. Frugal engineering, I learned this word from Marshall Cursor. Frugal engineering is the key. If I want to execute this is the amount that has been given to me. Now I will work it in a reverse manner and allocate funds at different levels of this program. Decide the outcome measuring parameters. There should not be fights on that. So whatever is the outcome, how am I going to judge? What are my standards? So set up accreditation councils and liaison committees in your institute, which will talk to the national organizations for multiple stakeholders outcome assessment tools. Now, what are the barriers? Why does IPE not succeed or not take up quickly? There are many people in every organization. Whenever you want to do anything new, they will say, is it worthwhile? हमारे ज़माने में ऐसा कुछ नहीं था. अरे भैया तुम्हारा ज़माना गया. That you don't understand. So is it worthwhile? Are there finances? Where is the time? I'm the very busy person. I mean, Gandhiji or someone had said it brilliantly that if you want to get a job done, give it to the busiest person. And just make him understand the significance of that particular thing. Space and classrooms, curriculum. Is it extra work and will I get some allowance for that? That is an important academic question. Okay? Resistant to change. How to sync various classes and streams and how can we assess commonly? These are the barriers. I can tell you the difference between perseverance and obstinacy is that one comes from a strong will and the other one comes from a strong want. If you forget all other barriers, they are manageable, but the barrier of attitudinal change is the only and the most important thing that you need to overcome. So what is my suggestion? I'm not the one who would only put problems. What are my suggestions to the institute? One, accept IPE as an institutional goal. Now this is important. Once symbiosis, once something accept it as an institutional goal. आपको symbiosis join करना है तो ये goal आपने accept किया है. That's point number one. Second thing, set us some budget, whatever budget you might give. Three, identify faculty champions, people who strongly believe in making this change happen. Those are the faculty champions. Establish relationship with other health programs, maybe national health programs like Ayushman Bharat, Mahatma Phule Yojana, Rashtriya Bal Suraksha Yojana, whatever things are happening. Establish IPE planning team in your organization. Choose the themes, set small and go slow in preparedness. Reward the faculty. Small rewards ultimately make the horse win the race. That is important. Academic scholarships and assessment programs. Let me now actually come to the practical aspect. If you say me, sir, we want to go ahead in symbiosis, we have a simulation lab. The whole 2 days conference theme is very heavily based on simulation. And as my predecessor speaker also talked a lot on simulation, can we actually do IPE using simulation? Let's dedicate some time to this. Yes, we can do it for surgery, for surgical nursing, for perioperative care, how to prepare for surgery, how to tackle complications. All these things, interprofessional education and healthcare education can intersect each other. Dear friends, these are the two institutes who have a very, very coveted place in my heart. I was a postgraduate student when I joined KEM Hospital in 1986. I was ridiculed as a Gawwala because I was coming from Mirrors Medical College and I was a Gawwala, let's believe that. 27 years down the line, I became the director of that hospital and then led it for the next 4 years. I learned my surgery, I professed my surgery, and I continue to do so even today in KEM Hospital and its sister concerns. And on the right-hand side is the Royal College of Surgeons of Edinburgh, which bestowed an honorary fellowship of FRCS because of my surgical contributions on them. So I learned surgery academically in these places. But I perfected surgery in D.Y. Patil, Navi Mumbai, Mumbai, when I was the Vice Chancellor, and when I set up the first of India's simulation laboratory in a private sector, and it still stands today with a tall head. And that was the D.Y. Patil Medical Simulation Laboratory Unit. How does simulation help you in IPE? Well, it understands physiology. It comes to know the effects on milieu interior. Intensive monitoring of the patients become possible. And it also gives you an opportunity to understand the mechanics of monitors and the instrumentation that you are using. It goes beyond technology. Many people feel that, oh, you need 8 crores, 10 crores, or I will put in 10 crores and you design a lab for me. No, it is not that way. It is going beyond technology. It's a thinking process. You have to unlearn quite a few things. When he himself comes out, idhar maine galti kiya, I should have done it better. That's the best way of learning. So if you want to make intubation a child's play, you need to have IPE and multiple stakeholders coming together to teach and learn. Example 2, wrong medicine, wrong dose being given in a hospital and in a ward. So common that it will virtually shake you eventually. Can you use simulation? Yes. Clinical, pharmacy, nursing, and clinical nurses coming together in the ward. Again, an example of IP when you can pick up a consumable mismatch, a drug interaction, a drug adverse effect, and an adverse event reporting. Patient safety, patient falling off a trolley. One of the common things that happen, radiologist पाठवला होता patient trolleyवरनं पडला, and then how do you explain it? Again, can you take care of iatrogenic errors? Can you take care of various instruments that are connected to such patients? What are the faculty people that can come together? Surgeons, intensivists, technical staff, nursing, and the administrators who write down the right protocols. Doing a good tracheostomy, doing surgeon and a nurse is the God's greatest gift to an ailing patient because it is available at that particular moment when it is required. But again, you can profess well in few seconds provided you have had a curriculum and a task of IPE, people working together. Setting up an IV line, it's not a child's play, particularly for a black patient, a fatty patient, burns, or a baby. It's a hell out of a problem to set it up. But yes, this is an example for an IPE. Doing a surgery such as an appendectomy or doing a delivery. I have written my last book, which is actually a translation of Professor T.E. Udwadia's autobiography. And one of the chapters in the book is making a surgeon. सर्जनची जडणघडण आणि महाराष्ट्राला कशा किंवा भारताला कशाची आवश्यकता आहे. And sir very rightly said, rural health center to be converted into a hospital where a doctor will be able to take care of a perforative peritonitis and an appendix, deliver a baby by a cesarean section, and treat a compound fracture. If you can do these things using whatever you want to do here with IP, you can save a lot of lives. That is the important message. There are simulators available where you can simulate anything and everything in pregnancy. I had a simulator which used to have twins, shoulder dystocia, arm prolapse, placenta previa, postpartum hemorrhage, everything. And the simulators were so real that we could prime that simulator to talk, cry, shriek, and even at times give galis to her husband. Cardiology simulators, again for a heart attack, for arrhythmia, ECG technicians, nurses, doctors, everybody working together. An entire cath lab where you can profess an interventional cardiology, doing an angiography, doing an angioplasty, an entire interventional vascular lab when you can do with multiple aneurysms, thrombosis, injecting stuff, all these things are part of your work. Can IPE and simulations help your administrators? Yes. It can tell you the trends, it can tell you the statistics. Right now, the task force and I am deeply involved in studying the post-COVID effects, not only on an individual patient, but the entire health sector of the state and the country. And we have changed completely prior to 2019 and now what we are. And simulation in healthcare can help you in patient admissions, in resource allocation, in doing a population survey and predicting the trends. These are some of the good journals where you can find good information about IPE, about role of simulation, and I wish that the university subscribes for these. Let me show you some of the examples of the best simulation labs that are available today in the world. It all depends on your objectives, your resources, and the amount of land that is available to you. Whether you want to allocate one floor or whether you want to allocate one building to simulation. It all depends on your pocket. So some of the various labs that are available today. This is from Calgary. Just have a look. This is from Brazil. This is from University of Alberta, a nursing simulation training center where you have an entire ward created of patients and every patient simulation can tell a different nursing program. Making of a bed karni, is one of the arts of a good nurse. And I can make, which is a good nurse, from one which at the least possible time make a good bed. All these things can be professed on this. Thomas Jefferson University, again a college of nursing. And this is what I set up in 2013 when I became the Vice Chancellor. It's D.Y. Patil University Medical Simulation Lab. What we had, a sim man. This gentleman, you can create any scenario that we come across in EMS, trauma, fractures, arrhythmia, pneumothorax, foreign body in the bronchus, anything that you say can be created on a sim man, an advanced version of METI man. Similar things in pediatric age group. And this was my most favorite, a laparoscopic simulator. Whenever I had free time, and as a Vice Chancellor, I had a lot of free time. And my office and the lab were next door to each other. So I used to get up and perform my skills of lab cholecystectomy. And the simulator used to take me to a next advanced level of difficulty. I didn't realize that I'm professing and I'm perfecting. Day before yesterday, when I did a 7-year-old lab cholecystectomy, the operating time was 11 minutes, skin to skin. This happens because you worked on that. Debriefing, and this is the center core of D.Y. Patil University lab, when you all sit in a cuddle and then discuss what went wrong, what could have been done better. And this is a classic example how an interprofessional team should sit together. I also created a virtual teaching classroom just next to that. This is the virtual teaching classroom of D.Y. Patil University. And you can get connected from this classroom to any corner of the world. So this was a Harvardian method. Nobody gave lectures. We just declare this is the topic for discussion. The students must come with their mobile phones, iPads, laptops, whatever they want, but there will be only discussion on that topic. So this is second thing that becomes a helpful thing of IPE. IPE also gives rise to collaborative research projects. That's the beauty. Taking cues from D.Y. Patil, Ennapoya University in Mangalore set up another extremely good laboratory. They called me for inauguration. And I can today tell you that this lab probably matches what D.Y. Patil, or they have an independent building for this particular medical simulation laboratory. Apart from that, coming together also brings out the best on the soft skills of group interactions, role play for verbal communication. Breaking the bad news when a patient expires is an art in itself. It's not science. And this art can be perfected by IPE. Choosing the right words, having the right kind of emotions, having the right kind of body contact, all these things can come up in an IPE. What is a SWOT analysis as I come to the end of my presentation? Public hospitals feel that there are too many cases to learn from. We don't need such kind of IP and simulation. हमारे पास time ही नहीं है. बस patients ही patients है. Private people feel, is there return on investment? मैं 20,000 रुपए fee रखूं course का? I said nobody will come. People cannot afford it. This is an idea whose time is now coming. When I did it about 10 years back, it was an idea whose time was yet to come. Senior professors feel that they know everything about interprofessional education and simulation curriculum just by the virtue of their seniority, which is again a bubble, which is not true at all. In fact, a youngster might know it better of how to teach and what not to teach. Students को यह लगता है कि यार ये कुछ real नहीं है, वो जो मरा वो patient नहीं था, simulator ही था. So they may feel that this is not the real thing. Simulation never replaces ward work. This is the most important statement. It just prepares you for a better ward work. Sky's the limit to stage the applicability. When I set up this lab in DY, I had very limited objectives. By the time I completed my term and moved ahead in my life beyond VC's chair, we had 28 programs written down where we could do 2.5 days courses in the laboratory. I was happy with my MD, MS, DM, MCH guys till second MBBS professor came and said me, sir, forensic medicine pe simulation karte hain. And then all the toxicology could be converted into what are the types of arrhythmias and problems that came. Then the physiology colleagues came and they said, sir, various types of heartbeats, murmur, S1, S2, aortic, systolic, all those things can be done on a simulator. Yes. So dear friends, sky is the limit. And you can stretch it to whatever levels you want. Soft skills trainings and opportunities galore right from first year to consultants. Now, this is for administration and for policy people. Does every college need a lab like this? Give me 2 minutes, dear, which is about 10 crore plus? The answer is no. In India, the problem is, bhala meri kameez uske kameez se safed kaise? We have to come out of this mentality. You should not have a lab like this. But you set up a department with 3 chairs. There will be a professor, AP, and an assistant professor for this particular work. Provide a funding for their salaries. Include in the UGC mandate whenever you are starting a medical college. It's only a recommendation. It's not mandate as it. Make a hospital clinic audit annually and create a consortium of 5 colleges or hospitals, 300 beds, less than that. A hospital more than 300 beds should have a simulation lab, a limited capacity simulation lab. A medical college of 500 plus should have a simulation lab. But something is less than that, 50 admissions, 100 admissions. Okay, in a 5-mile radius, create a consortium and have one lab, create a hub and spoke model, which will eventually be cost effective. You should have a society. We, in fact, have a society. It needs to be strengthened. It should come out with a journal, e-meetings on a monthly basis. How this could have been done? How this could have been done in an IPE manner? Annual international events, dialogue with National Board of Examinations. We are moving ahead with OSCE patterns in assessment and how IPE will help in that. When I was a medical student, when I was a postgraduate student in pediatric surgery, perfecting it under my illustrious teacher, Dr. Mrs. SYMHEALTH Deshmukh, one of our journals came out with a brilliant article. It was about, we have a condition called as imperforate anus, when the anus is not exteriorized and we need to bring it down. All these years, we used to open the abdomen, get it down. For the first time, a new method was being described. When we didn't open the abdomen, we opened the baby from behind and got the anus down. It discussed the old method and the new methods, the old way of teaching and the new way of doing it. And the title, I still remember, this article was published in 1989. I still remember the title of the article, and it said, "The bath water needs changing, but don't throw the baby out." That is the message of this lecture. Don't guess about the future, simulate it. Don't guess about IPE. It's already here. The future of simulation for the healthcare, the future is here. I close my presentation with a small story that I heard from, again, Dr. Mrs. Deshmukh. It deals with any change. It deals with any outcome. In a village, there was a very saintly personality, very illustrious, Sadhu Purush. And there were few troubleshooters, mischief mongers. One day decided कि इसको कितना आता है, इसका ज्ञान टेस्ट करेंगे. So they got a small bird in their hand, went to that Sadhu Purush and asked him, Sadhu Maharaj, ये जिंदा है कि मरा हुआ है, ये आप बताइए. The idea was, if he says जिंदा है, clench the fist, kill him, and prove the sadhu wrong. And if he says mara hua hai, open the fist, let the bird fly, and again prove that the sadhu was wrong. Sadhu looked at it, smiled, and said, the fate of the bird is in your hands. That is what IPE stands today. Thank you.
Thank you, sir, for such a valuable session.
I now request Dr. Rajiv Yeravdekar, Dean Faculty of Health Sciences, to felicitate Dr. Sanjay Oak.